this is better.
Yeah.
Okay, so I'm going to talk about the outcomes of bariatric surgery just because of obviously the limited time available to me. I will not be able to do the whole sort of outcomes of it, but some of the important relevant one. And I'll just actually say I have no disclosure. And one important thing is, as you can see in my title, I'm not a surgeon. Most of my colleagues in the meeting are surgical, but I work with surgeons very closely. My job is in renal transplantation, so I'm with the surgical team all the time doing ward rounds and things. So I know a little bit about surgery. Okay, so background is obviously, as we all know, that obesity is increasing globally, and it is a chronic condition, chronic disease. The good thing is it's treatable and it can be prevented. Just obviously, some of my slides are some information is very basic, but it's important obviously to bring all these things into the context. So this is obviously the different grades of obesity. As you can see, we use a BMI to classify the patients into different weight categories and then to obesity categories. And I'll just actually say the obesity obviously starts from 30 BMI or above, and then there are different grades of it, grade 1, grade 2, grade 3. Obviously, one important thing is for Asian people, especially from subcontinent, the criteria is slightly different. So the normal for them is like somewhere between 23, 22 and a half to 25 to be normal. And obviously for other population, it is slightly higher. This is obviously doesn't need much clarification, but we know that obesity is linked with increased mortality and morbidity, and this has been shown in multiple studies, and multiple sort of international bodies have recognized it. This is obviously from WHO that overweight is killing more people as we speak compared to the underweight population, and this is evident from this nice graph that you can see a J-shaped graph. When a patient is very malnourished, the mortality is high. It is on this end of the graph. Then obviously it drops down and goes up as the BMI goes up. The x-axis is showing BMI. As you can see, BMI around 25 in most of the population, you get the lowest mortality and morbidity, but on either side of it, you get obviously higher mortality. Then these are obviously the medical conditions which are associated with obesity, such as diabetes, hypertension, coronary artery disease. You can see obviously that as the BMI increases on the x-axis, the risk of getting these conditions increases. And for diabetes, you can see it exponentially increase after obviously the BMI of around 22 or something. So coming quickly, obviously, to the management of obesity, these are the three important sort of areas of management: the diet, exercise, and lifestyle changes, medical therapy or pharmacotherapy, and bariatric surgery. These are the three major sort of methods to treat this condition. Diet, exercise, and lifestyles are usually advised for as a first-line treatment. And then obviously patients move to pharmacotherapy and plus minus bariatric surgery, depending on their intense severity of obesity. Now, the problem with the medical therapy and with the lifestyle changes is that most of the patients at some time obviously are very enthusiastic to lose weight, and they do lose weight with those methods. The problem is it's very difficult to maintain the body weight in the long run at a lower level, because once this enthusiasm drops, actually they start eating, they go back to their normal eating habits and put on weight again. Bariatric surgery obviously is indicated in certain types of grades of obesity, and these are recognized by most of the international bodies who obviously deals with obesity and diabetes. According to the American Diabetes Association, the BMI of 40 kilogram per meter square or above is considered as an indication for bariatric surgery, or a BMI of more than 35, but with one or more other comorbidities related to obesity can be considered for bariatric surgery. There are two different types, major types of bariatric surgeries in practice. The restrictive types, which include adjustable gastric banding and sleeve gastrectomy, and the combined modality, which includes restriction of the food, plus obviously malabsorptive mechanisms that include Roux-en-Y, gastric bypass, and paleo-pancreatic diversion. I will not go much into the details of the surgical aspect of it because it's a long one can actually talk about it for a whole day conference, but just to let you know, obviously these are some of the pictures. So the first one is the sleeve gastrectomy, and the second one is the Roux-en-Y gastric bypass surgery picture. The third one is the gastric banding, and the last one is the biliopancreatic diversion operation. Now, coming obviously to our current practice, this is data from 2018 from United States. And in United States in 2018, more than 250,000 cases were reported, procedures were done. Almost more than half of them were sleeve gastrectomy. About 17% were Roux-en-Y gastric bypass, and less than 2% were the other types of bariatric surgery procedures. So the most common ones were sleeve gastrectomy and Roux-en-Y GB. Most of the information in the next few slides will be related to these two types of surgeries, because the other surgeries are not happening as frequently as they should be due to complications and other problems associated with them. Now, coming to the outcomes, obviously, as evident from the name of the surgery, it is aimed for weight loss. And I must say the data is very strong. It's very robust data to say that bariatric surgery definitely give a significant weight loss compared to lifestyle changes, diet, and pharmacotherapy. There is no doubt about it, and I'm not going to talk much about it because it's all very clear. Now, the other benefits are beyond the weight loss, which include metabolic benefits, cancer risk reduction, functional outcomes, and psychological effects. I will talk about the metabolic benefits more, and the other ones I can briefly tell you that there is definitely improvement in cancer risk reduction, and patients become more mobile, have reduced joint pains once the body weight comes down. And the metabolic effects are obviously mainly around the metabolic syndrome. As we all know, metabolic syndrome is a combination of type 2 diabetes mellitus with hypertension and dyslipidemia. These combinations may not be there in all the three components may not be there in every patient, but at least two of them usually, when present, we call it metabolic syndrome. And this is usually seen in the context of obesity. So obesity plus these conditions make it obviously metabolic syndrome. When patients undergo bariatric surgery, we see improvement in all the components of metabolic syndrome. I will come to type 2 diabetes mellitus because there's a lot of data available about the improvement in type 2 diabetes mellitus. I mean, in our clinical practice, we normally diagnose diabetes using these criteria. These are pretty common at a global level. So hemoglobin A1C less than 5.7 is normal. Oral glucose tolerance tests when the glucose level is less than 140 milligram per deciliter, that is normal. And fasting blood glucose of less than 100. Obviously, then there is a stage of pre-diabetes, and then there is a full-blown diabetes, and you can see obviously the numbers. I will not waste your time on these numbers, but it's just actually to bring it to your attention. As obviously you can see, this is data from England, and this is pretty consistent with other countries' data, similar data from US as well, that the risk of type 2 diabetes increases as the body weight increases. As you can see, obviously, on the right side of the figure, the patients are obese and overweight, and you see more risk of diabetes, both in younger people and in older people. Now, the bariatric surgery has shown beneficial effect both as a preventative measure and as a measure to remission or completely curing the condition. which is very unusual because none of the other medical therapies or none of the dietary or lifestyle changes have shown a complete cure. So as you can see, obviously, it can induce durable remission and can also cause prevention of diabetes in obese patients. And the mechanism of remission is complicated. Some of it is not fully known. Some of these areas are still in hypothesis stages. But the consensus is that it improves the beta cell in the pancreas. The function gets better. That's why they go into remission. Insulin sensitivity improves as the body weight drops down. And there are obviously some changes in the adipose tissue, which is considered as an endocrine tissue nowadays. The endocrine function changes as the body weight comes down. But I must actually inform you guys that the effect of the bariatric surgery is not only related to insulin and reduced body weight, it obviously is also related to more than the body weight. And because we start seeing improvement in the blood glucose levels immediately after the bariatric surgery, well before the body weight goes down. So there are other mechanisms of improving the blood glucose level. The diagram actually shows the different ways in which impact positively on the blood glucose levels. I will not go into much detail, but I just wanted to show you that there are multiple mechanisms which are operational at this level. Now, from prevention point of view, this is a very large study. As you can see, more than 370,000 patients were included. This was done in France. It's a case-controlled study. These were obviously the baseline information before the study started. They looked at obviously included control patients which were not yet diabetic and they were obese. And then obviously they looked at patients who had surgery for obesity and saw what happened to their diabetes in the future. So the surgery in this study included the gastric banding, gastric bypass, and sleeve gastrectomy. And you can see, obviously, this was the data. It's the patient flow, but also that gives you the data that about 13.2% of the patients in the control group, which did not receive bariatric surgery, developed type 2 diabetes mellitus during the study. Now, looking at the gastric banding, only 4.5% of the patients developed diabetes. Gastric bypass patients, only 1.2%, and sleeve gastrectomy patients developed only 0.9% of them developed type 2 diabetes. So that is a clear indication that it prevents, obviously, the risk of or the incidence of diabetes. Now, for patients who are already established diabetics, some of obviously the studies looked at those patients who underwent bariatric surgery. And it has actually, multiple studies have shown that it causes remission or improvement in the diabetes control after the bariatric surgery. So this is one of the randomized controlled trial. The primary aim of the study was a partial or complete remission of diabetes mellitus. So partial remission is, if you go back, obviously, to the slide when I was showing the different levels for diagnosis of the diabetes, the partial remission is considered actually the criteria meeting the pre-diabetes, and complete remission is when the patient has completely normal blood glucose levels without any medication. So this was what they were looking at. They compared obviously patients who had bariatric surgery with those who were given only medical treatment. And obviously I can tell you the treatment was intense lifestyle, a weight loss program for 1 year, and then followed by a slightly less intense for next 2 years, which was the total duration of the study, 3 years. Bariatric surgery patients actually had bariatric surgery, and then they were advised to have a low level of lifestyle intervention. And let me tell you, yes, yeah. So these were actually the improvement in the diabetes. So partial or complete remission of type 2 diabetes was seen in 40% of the gastric bypass patients, 29% of the gastric banding patient had complete remission or partial remission. None of the patient in the medical treatment achieved complete or partial remission. They obviously continued to be diabetic and then required medical treatment. And this obviously was statistically significant. This is another diagram, obviously, of the same effect. You can see, obviously, in the Roux-en-Y gastric bypass, a lot of patients achieved remission. And the same was true, obviously, to a smaller proportion, but it was seen in gastric banding patients. And this was obviously the lifestyle change group, which did not achieve any remission or partial remission. And then you can see, obviously, the durability of the effect of the remission continues up to 3 years in most of the patients who achieve the remission. This is another randomized controlled trial looking at comparing, obviously, patients with gastric bypass and those who went on medical management and lifestyle intervention. They looked at, obviously, multiple factors of the aspects of the metabolic syndrome, like the cholesterol levels, the hemoglobin A1C levels, the blood pressure. 120 patients were included, and this was total follow-up of the study was 12 months. The endpoints are obviously composite, which is like a combination of hemoglobin A1C less than 7, low density lipoprotein, cholesterol less than 100, and systolic blood pressure less than 130 millimeter of mercury. These were obviously the findings. So you can see this graph, the blue line obviously represents the lifestyle and medical management. The orange one represents gastric bypass surgery. And you can see the orange one line is always less than the green one, which basically shows that it achieved the study target. So hemoglobin A1C was lower in the bariatric surgery patient. Similarly, systolic blood pressure was better controlled. Obviously, more patients achieved better weight loss with bariatric surgery, and low density lipoprotein was also low in the surgically treated patient compared to the medical treated patient. This is another randomized controlled trial, which compares, obviously, in obese patients treated with conventional medical therapy and with surgery. And they were looking mainly at type 2 diabetes, 5-year follow-up study. This is just a patient flow that most of the patients completed the study. There were some patients who went out of the study for obvious reason. I can show you, obviously, that patients who underwent bariatric surgery, they did here gastric bypass and biliopancreatic surgery. This was an older study, so biliopancreatic study was obviously more used in the past, but not anymore. And you can see, obviously, none of the patients in the medical treated group achieved partial or complete remission of type 2 diabetes. That there was obviously definitely more numbers of patients in both the different types of bariatric surgery who achieved a partial or complete remission of type 2 diabetes, and this was statistically significant. This is another graph from the same study. I just wanted actually to bring this to your attention, this part of the graph. You can see, obviously, a lot of patients. The gray area means those patients who did not require any treatment after the surgery. And you can see there is no gray here in the medically treated patients, but there are gray in both the different types of bariatric surgery, meaning that they completely went off the medical treatment and still maintained good glycemic control, which in other words, you can call it a cure of the type 2 diabetes mellitus. I will skip this for the sake of time. I've already discussed some of the studies here, but this is like a meta-analysis type of review. And it shows basically the same finding, that all of the studies showing that bariatric surgery can induce remission, either partial or complete in patients, which is never ever achieved with medical treatment only. Yeah, again, same message here. Well, this is another study, obviously, which shows the effect of different types of bariatric surgeries, showing which one is to try to find out whether there is any better option. better surgical procedure, which can give better outcomes in terms of remission or partial remission of this diabetes. So they didn't find any statistically significant difference between sleeve gastrectomy and gastric bypass. Both achieved similar results. Again, this is another trial, and this was again not showing any statistically significant difference between the sleeve gastrectomy and Roux-en-Y gastric bypass. These are actually some studies which looked at the diabetes complications, patients who had diabetes with complications, what happened to those complications. So the complications are mainly two different types, macrovascular and microvascular. Macrovasculars are coronary and cerebral vascular disease, and micro includes kidney disease, retinopathy, eye disease, and neuropathy. All of them actually improves after bariatric surgery. And these are actually some of the studies. This is a meta-analysis which includes both observational and RCTs. Quite a big number of patients were included, obviously 15,000. And it included RCTs and observational studies. And they basically, the odds were in favor of bariatric surgery in terms of improvement of the complications of diabetes. So patients who underwent bariatric surgery had better or improvement in the complications of type 2 diabetes. Now, a few important things, and I'll come to an important conclusion from this, is that the patients, obviously, as you can see in all the studies, 100% of the patient did not achieve complete remission or partial remission. It was obviously less than 100%. So there were some patients who never achieved complete or partial remission even after doing bariatric surgery. The reason they have actually identified a few factors, and this is consistent in all the studies. There's patients who had actually a shorter period of type 2 diabetes mellitus, patient who had lower hemoglobin A1C before doing the bariatric surgery, and those who were not on insulin, they responded in terms of very well, and they achieved a partial or complete remission. Those who had complicated long-term uncontrolled diabetes mellitus did not achieve remission. Now, basically, what it means is that we should not actually wait for the type 2 diabetes mellitus to develop more complications and get more severe in the disease itself. Rather, actually, we should intervene earlier in this disease process with the bariatric surgery so that we can achieve better results. And this actually has been recognized by some of these international bodies. One of them is the Diabetes Surgery Summit Consensus Guidelines, which actually is recommending to do bariatric surgery in those patients with poor glycemic control with medication, but with the BMI of 30 to 34.9. If you remember, the guidelines actually are talking about doing bariatric surgery in those with BMI of 40 or above, or 35 or above with comorbidities. But now here, the criteria is changing, or it is recommended to change it, to drop it down to 30 rather than 35 with diabetes. Now, the other part of the metabolic syndrome is hypertension. Again, one of the best study for this is the Gateway study. It's a randomized controlled trial, and it was purely done to look at the antihypertensive effect of the bariatric surgery. What they did is basically they included patients with 30 to 39.9 BMI who are on more than 2 antihypertensive medications, maximum doses or at least moderate doses. And then they were randomized to medical treatment or to surgical treatment for bariatric surgery, followed for 12 months. These were the baseline characteristics, and they were very similar. But the primary aim of the study is to achieve more than or 30% reduction in the antihypertensive medications and still maintain the blood pressure at around less than 140/90, which is our sort of criteria for general population. This graph, obviously, it's a bit complicated, but I'll explain. The blue bar represent patients who achieved the study criteria, the primary aim of the study in the surgical group. The red bars are the ones which were treated medically and they achieved the study primary aim, which is less than 30% antihypertensive medication. As you can see, at different times in the 12 months, the patients who underwent surgery achieved the study primary aim more, or almost reaching to 80% compared to the medical treatment. And the lines actually here shows the body weight changes. Obviously, after bariatric surgery, the body weight fell down significantly compared to the medical treatment. So clearly showing, obviously, that the bariatric surgery has a role in improving the blood pressure control by reducing the blood pressure tablets. Well, I must admit that the data is not as convincing as type 2 diabetes mellitus. And obviously more studies are needed to explore this thing. And I wouldn't use, obviously, hypertension only as a guide, as a criteria for doing bariatric surgery. We can treat that with medical treatments, and obviously newer medical treatments are coming in hypertension, which may have better results. Yes, I'll leave it. Both Roux-en-Y gastric bypass and sleeve gastrectomy have similar results, so there is no difference in the type of bariatric surgery, but both of them improve the hypertension. The last part of this is the dyslipidemia, or increased cholesterol level and other lipids in the blood. And this is pretty common in obese patients, and that we define dyslipidemia as a high triglyceride in the blood, or high low high density lipoprotein, or high level of low density lipoprotein. So patients may have one or two or all the three components of the dyslipidemia at the same time. Now, again, bariatric surgery improves the dyslipidemia. This is obviously a randomized controlled trial with 5-year follow-up. I just summarized the dyslipidemia levels. So in this study, obviously, triglyceride came down more significantly in the surgically treated patients. So minus 40% from baseline in gastric bypass, minus 29% in sleeve gastrectomy, compared to medical treatment, which was only minus 8%. And this was statistically significant. Similarly, HDL, the high density lipoprotein, went up 7%, which is good. The higher the HDL, the better it is. So only 7% patient had a high HDL in medical treatment, while 32 and 30% in the surgically treated patients. Now, which procedure obviously achieves better results in terms of the dyslipidemia? So far, I think both of them are, the Roux-en-Y actually shows better results, but obviously we're not using dyslipidemia as a primary indication for doing dyslipidemia for bariatric surgery. Sorry. So the aim obviously is the guidelines are not suggesting to use hypertension or dyslipidemia as an indication for bariatric surgery, but as I showed, that some guidelines are changing it for type 2 diabetes in obese patients. I think this brings me to my last slide. This is my last slide. I will stop here. Thank you very much for listening, and I'm open for questions.